Good evening, everyone. Welcome to session 16 of the SCTS Foundation Doctor Academy. I'm pleased to be joined by Mr Mohammad Hawari, who's a Consultant Thoracic Surgeon at Nottingham University Hospitals. And tonight he'll be talking to us about pre-operative assessment in thoracic surgery.
Good evening. Thank you so much for inviting me to give this talk. Pre-operative assessment in thoracic surgery is a very important topic, and it basically covers all the basics that we do whenever we consider a patient for a thoracic operation. So the objectives of the talk this evening is to understand the difference between what is operable and what is resectable. What do we mean by tripartite assessment? What is Thoracoscore, something that we use like the Euroscore for cardiac surgery? What is performance status and how is it assessed? How do we calculate predicted post-operative lung function? And apart from lung function, what other tests can predict the risk from a thoracic surgery perspective? And then we're gonna just discuss some scenarios just to see how we can apply what we have learned. So the question is, if you have a look at this X-ray on the right and this relevant CT scan, you can see that there is disease in the top part of the right lung, which is involving most of the lung, but also crossing all over to the hilum. And it is involving the right main bronchus, it's involving the distal part of the trachea, just at the level of the carina. And on the CT scan, there is a lymph gland, which looks like enlarged, maybe involved in the right side. So the question is it resectable? Is it a disease that I can remove surgically? And am I able to achieve a complete resection? Am I able to achieve an R0 resection? R0 means that all the margins are clear with no evidence of any microscopic disease. R1 is microscopic disease is left in the patient, and R2 is that there is visible macroscopic disease that is left. And the second question for any patient that I'm going to operate on is that patient operable? And this means that would the patient tolerate the proposed operation that I am going to do? Will that patient tolerate a lobectomy or a pneumonectomy or a carinal pneumonectomy? Is the surgery the right treatment for this particular disease? We don't know, for example, the diagnosis. This could be small cell cancer, and small cell cancer usually is not treated by surgery. And is there any evidence of disease spread? So it's not good that you go and operate on a patient and do a big heroic operation and without really, investigating the patient appropriately when the patient already has, for example, a liver metastasis or adrenal metastasis. So it's important that you ask yourself these questions all the time. Are you able to remove the tumor without any disease left? And will the patient really tolerate it? Is this the right treatment for the patient, and has the disease spread? So this is how we think about any patient who's coming to us. Now, any patient as well coming to my clinic, I would like to do a tripartite risk assessment. So I start assessing the patient from me calling the patient into the clinic. I go and collect the patient myself. I go and walk with the patient, see how they leave their chair. Are they on a wheelchair? Are they using a walking stick? Are they struggling to walk? How long can they walk from the reception area until they reach the clinic? And when they sit down, are they having a high respiratory rate? How are they coping generally? So all of this is really important. They are, quick sort of visual assessment of the patient. The operative mortality is that you're going to assess what is the risk of the operation to the patient, what is the chances of this patient making it from the operation in the first 30 days, and what is the chance of this patient developing a post-operative cardiac event, and also how debilitated will the patient be after you remove part of their lung. Will they be very short of breath? Will they struggle? Will they end up on a ventilator? Will they need home oxygen? All of these things you have to be able to have a rough estimate at the end of your consultation, but you might need further tests to help you or to get the answers that you want. So how do we calculate a mortality from the patient? There are few modules that you can use for predicting risk of mortality from thoracic surgery. The one that is mostly validated and used is the Thoracoscore. and this is coming from a French society, and it has been tested on 15,138 patients, and they looked at the deaths that have happened in hospital after the operation. And they looked at, you can access this through their calculator. The calculator is available online, and it basically is a logistic model where it basically gives a value to certain categories. But they mainly look at the age, sex of the patient, ASA classification, the performance status, the dyspnea score, whether the surgery is urgent or elective, whether it is the procedure class, whether it's a pneumonectomy or not, the diagnosis group, whether it is a malignant or a benign, and then there's the comorbidity score, how many comorbidities does the patient have. And each one will have a value. So, for example, less than 55 will not have any value. 55 to 65 will have a bit of value. More than 65 years of age will have a higher value. Females have less risk, so they don't get any scoring. Males, they get a higher scoring. Urgent and emergency cases get a higher scoring. Elective doesn't, for example. And then you have your calculating your ASA grades. So if a patient is normal and healthy patient, you usually give them 1. If they have very mild systemic disease, then you usually say it is 2. If they have severe systemic disease, 3. And then if severe disease that is a threat to their life, then it is 4. And this is something that you always do in your WHO assessment, in your when you go to theaters and do all the assessment prior to proceeding with the surgery, you do that. So you have to know the ASA classification, you have to know the WHO performance status and how to calculate it. So for us, 0 to 1 is for a WHO is something that I am happy to consider for surgery. Number 2, I would like to assess them and see them myself to make sure that they are really not too bad. And most of the number 2s that I end up seeing in the clinic, they end up having an operation. Very rarely, if they are really 2 to 3, then I get slightly more worried. Those with 3, sometimes they are, for example, more dependent on a wheelchair for a problem related to the spine, previous fractures, MS, for example. So you really have to have a proper assessment of the patients. Not everybody with performance 3 you're going to exclude, but definitely they are higher risk patients. And obviously 4, you're unlikely to operate on them. The dyspnea score also applies. So that's the MRC dyspnea score. So you assess your patients, how bad are they from a breathing perspective? How far can they walk before they get short of breath? And so just have a look at your MRC dyspnea score and how it is calculated. Now, these are all the thoracic variables, the Thoracoscore variables that we use. We talked about pneumonectomy. This is the one that is calculated in this calculation model. And then the comorbidities that they look at. Obviously, if you don't have any comorbidities, then you're okay. But if you have comorbidities up to 2 from smoking, history of previous cancer, COPD, hypertension, any heart disease, if you're diabetic, particularly on insulin, peripheral vascular disease, obesity, alcoholism, and hyperlipidemia. These are things that we see in many of the patients that we operate on. So their Thoracoscore and risk of mortality will definitely increase as the number of comorbidities they have increases. So the more comorbidities they have, each one will score on that. And then you do your calculation, as we said on this, and it will give you your Thoracoscore, the risk of mortality from the operation that you are going to provide these patients. On average, for somebody, if you look at the blue book and what we have in our SCTS database, for patients who are straightforward, who don't have much comorbidities, for a lobectomy, for a VATS lobectomy, we're talking about approximately 1 to 1.5% mortality. For an open, it is around 2 to 3%. Pneumonectomy can be between 5 to 6%. Other procedures like oesophageectomies can be between 7 to 8%. So these are just rough estimates. The more comorbidities you have, the higher the risk, obviously, you'll quote. But the Thoracoscore is a reasonably okay calculation method that you can use when you are trying to predict a risk life for these patients. Then we have to go to the second part of the tripartite assessment, and this is basically assessing the cardiovascular morbidity. So I usually quote a risk of 1 to 2% of risk of MI or cardiac death after a lung resection, but this obviously increases as the patient has history of cardiac disease in the past. And I sometimes also look at the CT scan and look for coronary artery calcification, especially if it is really dense calcification that has already been commented on in the report. Even if the patient has negative history of ischemia, it just increases my worry a tiny bit. So I would probably increase by 1% the risk of them having a cardiac event. So any patient you are going to see, you have to assess them, examine them, and do an ECG for all these patients when they come to the pre-op clinic. Make sure that they don't have anything funny going on, no previous ischemia, signs of MI, no atrial fibrillation that needs to be addressed and treated before you take them to theatre. Any patient who has a murmur or who is short of breath despite having good lung function tests, get an echocardiogram for them. You want to make sure that they have good LV function, valves are not leaking, they don't have pulmonary hypertension. And any patient who is going for a pneumonectomy, definitely get an echo. The echo will help you a lot, especially if there is evidence of pulmonary hypertension. These patients, you probably should not be offering them pneumonectomy if they have pulmonary hypertension or significant heart failure. And patients who had an MI in the last 30 days, the recommendation is not to offer them surgery and sit tight, get them the treatment that they need and rescan them and then offer them surgery at that stage. If they are better, if they are not better, then they could be considered for other alternative options of curative treatment. So which patients do need to go and see a cardiologist? So if I'm in the clinic and the patient tells me, oh, I had an MI and I had cabbage and everything is okay, no angina since, I take aspirin, I don't get worried about them as long as their echo is okay. If a patient tells me that they still have unstable angina and they still have chest pain every day or every other day, they use their GTN on a regular basis, I get a bit worried about these and I send them for further assessment. So they might need to go through another angiography. They might need some form of stenting. But if the cardiologist is happy that they just optimize their medical treatment and they say, you can proceed, I would accept that at that stage after they have seen a cardiologist. Patients who have decompensated heart failure, who are not really on optimal treatment, also need to be seen by a cardiologist. Those who have runs of crazy arrhythmias every now and then, or really atrial fibrillation, which is uncontrolled despite being on medications, they need to be seen. Those who have severe valvular heart disease, they can be troublesome during the operation and immediately after the operation, and especially if they develop an arrhythmia on top of the severe valvular heart disease. So they can be a worry, and so they need to be seen by a cardiologist. So if none of the above, you can use what is called a revised cardiac index score. And this is basically looking at some factors that might predict that these patients might have a cardiac complication. So if it is any of these, so obviously it's a high risk operation, which is a thoracic, so they will score 1 already, and we'll be scoring them 1% risk of developing cardiac complication. If they have ischemic heart disease, history of congestive cardiac failure in the past, history of CVA, insulin and diabetic patients, renal failure, each one of these will increase the risk of them developing a cardiac event. Cardiac events unfortunately happen, and they are rare, but they do happen. And so it's important that you tell your patients about the risks and make sure that you manage them appropriately before you take them to the operation. Now, if there are up to 2 factors from what we have discussed here, you can take the patient straight to surgery as long as the symptoms are stable and they don't have any new onset symptoms. Anything which is more 3 or more, then you could consider other investigations by the cardiologist. So this is the recommendation from the ACC and the AHA guidelines regarding cardiovascular morbidity. Now, if you have a patient who is known to have ischemic heart disease and who is currently on aspirin, don't stop the aspirin, carry on. If you stop the aspirin, you would increase the risk of perioperative death and MI, especially if you stop it, for 5 to 7 days. Aspirin is extremely unlikely to cause any significant bleed, and we just operate naturally on these patients, and we will accept a tiny risk of bleed compared to an MI. The same applies for beta blockers. The beta blockers, you are controlling the heart rate. The heart is happy where it is. You don't want them to flip into an irregular rhythm, become hypotensive, ending up needing intensive care or inotropic support in the post-operative period. Usually this is a vicious cycle. The moment something sort of kicks off, everything else kicks off as well. So try to control things. Beta blockers, I will continue. Aspirin, I will continue. My policy for other things like DOACs, I usually stop them for 2 days. Warfarin, 5 days. If I need to bridge warfarin for a reason, like a stent, or if a patient is at high risk of coagulopathy, I bridge them with Clexane. Clopidogrel, I usually swap it to aspirin. That's my policy, as long as the patient is not allergic to it. I know some surgeons operate on clopidogrel, but most surgeons, they stop it and they swap it to aspirin. And if a stent is being considered, for example, patient has angina, whenever you write to your cardiologist, just tell them that you are planning to operate on these patients for the lung cancer soon, within the next 30 days. So if they could consider taking the type of stent into consideration whenever they are doing this. Then we come to the third part of our assessment, which is assessing how short of breath will the patient be after the operation. And as I said, my assessment starts from the moment I meet the patient in the reception area. So any patient, in the past, we used just to do spirometry for these patients and then operate based on that. If their spirometry FEV1 is good, we will just operate on them. But the evidence is that the TLCO, DLCO are really extremely important in assessing the risk of the patient and predicting mortality, and also predicting the post-operative dyspnea. So our figure that we always like to have is a predicted post-operative FEV1 and a predictive post-operative TLCO that needs to be more than 40% for the patient not to be extremely short of breath and to be able to tolerate the operation. So if you are able to achieve these figures after you do your calculations, then most likely this patient would be okay from an operation perspective. If it is less than that, then you need to consider other testing. Now, this has been the guideline for some time, and it has from the newer guidelines that are coming from NICE from 2019, and so NICE guideline regarding management of lung cancer, and also the European guidelines regarding risk prediction for lung cancer patients. They are talking about accepting figures down to 30%. So down to FEV1 of 30%, TLCO of 30% is okay, as long as the patient is aware that they most likely will be short of breath and that they might need home oxygen. They might need between 3 months to 6 months until they recover from their shortness of breath post-operatively, and they might not fully recover if they are, not mobilizing a lot, and if their lung does not really expand well. So it's important to be careful with these numbers. However, there are a group of patients who have emphysema, which is, for example, upper lobe predominant emphysema, and who might benefit from part of the lung, the emphysematous part, being taken out along with the cancer, and therefore they will not have the same effect as somebody who has a homogeneous lung, which is really emphysematous. So each patient, you need to apply your calculations carefully. but this is the rough guideline that we have followed for many, many years. So if you do your routine lung function and your FEV1 is more than 1.5, most likely this patient will tolerate lobectomy. And if it is more than 2 liters, most likely they will tolerate a pneumonectomy. If you want to be more accurate, I like to use the percentage. The percentage is really a better value for me as a surgeon, and I can predict better what's going to happen to the patient, because some patients are tall, they are big, they are large, some patients are very small. So the percentage will change according to their habitus, body habitus, and height and weight. So it's really important that you look at the percentage as well. So if your lung function is low, and so you do your quantitative lung scan, and then if your predictive values are more than 40%, then most likely surgery will be the right way forward. If there's a problem with that and your numbers are below 40%, then you can do exercise testing. So cardiopulmonary exercise testing, which I will show you in a few minutes, basically calculates something called VO2 max, which is the maximum consumption of oxygen during the exercise just before finishing it. And this is, if your number is more than 15 ml per kg per minute, most likely this patient will tolerate lobectomy. If it's more than 20 ml per kg per minute, most likely they will tolerate a pneumonectomy. If it is less than that, then they are at risk. So anything between 10 to 15 is a higher risk patient that you might consider doing a less resection for them, or maybe consider referring them for an alternative treatment, or they might accept surgery, but taking into consideration that they might need oxygen at home and they might accept the higher mortality. So how do I calculate a post-operative predicted FEV1 or DLCO? So the lung is made up of 19 segments. There are 10 segments on the right, and there are 9 segments on the left. So you have 3 in the upper lobe, you have 2 in the middle lobe, you have 5 in the lower lobe. In the left side, you have an upper lobe which is made up of a trisegment, so it has 3 segments, and the lingula, which has 2 segments. And then the lower lobe has 4 segments, and obviously the heart is taking part of segment 7. So this is how we calculate it. So if you have a predicted, if you want to calculate the expected post-operative FEV1, you have your calculation and you put 19 minus the number of segments. For example, if you're going to do a right upper lobe, you make 19 minus 3, divide it by 19, and multiply it by the original FEV1 percentage that you had. If that number is more than 40%, means that the patient most likely will be okay. Now, there are cases where the patient already has collapse of the part of the lung, maybe the whole lung, where they are not using it because of, for example, lung tumor occluding the whole left lung. So if the whole left lung is occluded by a tumor and you want to remove the whole left lung, you're gonna say 19 minus 9, and then because it is completely occluded, there will be nothing basically taken out. So roughly all your lung function that the patient currently has is dependent on the right lung, and the left lung is doing absolutely nothing. So even if you take the left lung out, the number, the predicted post-operative one, will be exactly the same, because the left lung is not contributing at all to the calculation. So let's do some examples. So this is a patient who has a tumor in the left lower lobe. You can see the fissure just there. And this is a bulky tumor, approximately around 35 millimeters. And let's say that the FEV1 was 2 liters, 80% predicted, and the DLCO was 80% predicted. So your post-operative predicted FEV1, the left lower lobe is made up of 4 segments, as we said. We're going to multiply 80% times 19 segments, which is both lungs, minus 4, which we're going to take out, divided by 19, and your number will be 63%. So the predicted post-operative FEV1 and DLCO for this patient, because they are the same, is going to be 63%. So this patient should pass that test from a respiratory perspective. Now let's look at this patient. So this patient is for a left-sided pneumonectomy, and already you can see that the left lower lobe is completely collapsed. the left upper lobe is still contributing. There is still some air going into that. So if we say that they are both 80%, the FEV1 and DLCO, the prior to the surgery one, then your predicted one, you're going to 19 minus 4, because you already lost 4 segments which are not contributing to the ventilation of this patient. And then you are going to deduct from them the 5 segments from the upper lobe that you are going to take out at the time of the operation, and then divide it by 15, which is the functional lung, the functional part of the lung, which is ventilating at the moment. And your number will be 53%. So if you're going to take the whole left lung out on this patient, you're going to be left with 53% FEV1 and 53% DLCO. So this is supportive of that this patient will tolerate an operation. Again, there are some other tests that you can do whenever you have a problem with your FEV1 and with your DLCO, and you can do ventilation perfusion scans, the VQ scan. And we both look at the ventilation component and we look at the perfusion component. But the one that really matters to us as thoracic surgeons, which is really more predictive, is the perfusion scan. So if you look at this one, the white thing is the amount, it's high perfusion basically coming in. So this is your right lung. It has the R upper, R middle zone, and R lower zone. So it works in zones rather than lobes. And this is the left side. You can see it is nearly black. So there is no much blood basically going into that area. And it looks at the posterior part and it looks at the anterior part, and then it gives you a geometric mean. So it calculates both and divides them. So that you can see the left side is only taking 8.1% of the output. So the perfusion is only 8.1%, while the right lung is 91.9%. So when you do your prediction models, the FEV1, you basically calculate based on how much the left lung is using and how much the right lung is using. So that patient would easily tolerate a left pneumonectomy because the left lung is really not doing much, and you can multiply it by the percentage of the FEV1 and the percentage of the DLCO to tell you how much figures that patient will still have. Now, other tests that we do include, so sometimes we don't have access to, for example, the cardiopulmonary exercise testing, and we might accept other tests. In the past, many consultants used to do the stair climbing test. Basically, they go with the patient, they go for a walk, and they go up the stairs, 1 or 2 flights of stairs. If the patient is able to do 4 flights of stairs, they really should be able to tolerate anything. If they're able to tolerate 2 flights of stairs, most likely they will be able to tolerate a lobectomy. 1 flight of stairs, it is predicting that a higher risk of shortness of breath after the operation, but most likely they'll be just okay and they might need a bit of oxygen. So the more the stairs that they are able to do, the higher the chance that they are able to pass the test. So this is just a rough estimate. But more accurate tests include the 6-minute walk test, which is seeing how much the patient is able to walk during 6-minute period and how much their heart rate is and how much is their respiratory rate is and how much their oxygen levels are. A slightly more accurate one is the shuttle walk test, which basically you will have 2 cones, and they're usually 9 meters apart, these cones, and the patient has obviously to rotate around them and go and rotate again, so the distance will become 10 meters. And every time they walk, there is the physiotherapist will have some form of a beeper, and they will press that so that they will know that they will have to increase their speed, so they have to go up a level in their walking, and they will be calculating their saturations and their heart rate during this time, and they will be seeing what is happening with them. Obviously, if their heart rate increases significantly, or if they desaturate, they stop it if they desaturate below 80%, or if they stay at 80% for a long time, or if the patient becomes very symptomatic with chest pain or shortness of breath, or if they have back pain or knees and so on. So there are some limitations, obviously. But if they are able to pass 400 meters and they don't desaturate beyond 5% and their heart rate doesn't increase more than 20%, they're usually okay. Anything less than that, if they desaturate significantly, for example, if they started on 95 and they became 80, then that gives you a prediction. Most likely these patients are not going to do well. If they start with a heart rate of 70 and then they reach 140 only by walking like 200 meters, this also tells you that their physiology is really bad. So it will give you an estimate and will tell you about how the patient will do. But the test is around 400 meters. Now, a much more accurate test, obviously, if the patient is able to cycle, so they have to have good knees and they have to have reasonable hips and they have to be able to cycle. So this, some people use a treadmill, some labs use treadmill, but most labs, they use a bicycle exercise. And you'll have continuous ECG monitoring, and you'll have this mask which calculates all the oxygen and carbon dioxide that comes out. And you have also the spirometry. And so they will be able to assess how much oxygen you're using, what is the maximal oxygen consumption, what is the peak heart rate that the patient has reached. It will look also at the exercise capacity, anaerobic threshold, your gas exchange ratio. All of these things are calculated, and it will be able to give you different things. So we look at the VO2 max as thoracic surgeons. We are interested in this number, but there are so many other things that will tell you. And sometimes these will tell you, for example, that this patient has a problem with the heart rate, and their heart rate, for example, is not rising well to respond to the exercise they are doing. So they have, for example, a chronotropic problem, and they might need, for example, to be referred to the cardiologist for consideration of pacing, for example. But for us, from a respiratory perspective, from a thoracic perspective, if everything else is okay and the VO2 max is equal to or more than 15 mils, as we said, this is usually a pass for lobectomy. And if it is 20 mils, then we are usually happy to offer them a pneumonectomy. So this is a more accurate exercise and a very good predictor. Now, other things that we need to consider whenever we are assessing our patients in the clinic and in the pre-op clinic. So we see the patients in the clinic, but also we bring them to pre-operative assessment clinic directly after that. And we need to consider things like enhanced recovery after surgery, with all its aspects. So we advise patients about stopping smoking. If there is a stop smoking referral clinic or service, we need to refer these patients to them because it will reduce the complications in the post-operative period. And most likely these patients will remain non-smokers on the longer run. Rehabilitation, some patients might benefit from referral to physiotherapy, rehabilitation gyms. That might help with certain exercises. Some people are using the gym, some people are using certain apps which are connected to physiotherapy teams. Medical optimization, so some patients with COPD, you might find that they might benefit from inhalers, they might benefit from beta blockers if they are in atrial fibrillation, or optimization of their diuresis if they have an element of heart failure. So these things can be taken into consideration. Alcohol reduction and stopping, especially those patients who are in high doses of alcohol, because it can predict post-operative complications, delirium, need for ITU. Sometimes they are not cooperative, they might not be coughing properly. So there are chances of developing problems here, and you might need to do some form of detoxification method for them. Nutrition is also important. So patients who have low albumin, they might benefit from having extra nutritional supplements prior to their operation. Anemia, something that also can be corrected through iron infusions prior to the operation as well. And so all of these things you have to look at whenever you are assessing a patient for thoracic surgery. Now we come to the surgical approach. So once you have assessed your patient and you found, for example, that this patient is slightly higher risk to consider a certain procedure, you might consider other surgical procedures. For example, instead of doing a pneumonectomy, you should always consider doing parenchymal sparing procedures, where you might do a sleeve resection on the bronchus, or you can do sleeve on the pulmonary artery and preserve as much of the lung tissue as possible. You should do it for every patient, not only for the patients with low lung function, because it has an extremely better value regarding their outcomes and prognosis. But if you have a patient who has a lower lung function, then considering sublobar resection, is absolutely acceptable, especially after the latest trials from Japan and from the States relating to tumors which are up to 2 centimeters with no lymph node involvement. So you have to make sure that these patients have the nodal dissection. You send them to a frozen section and make sure that there is no nodal involvement. And if the tumor is up to 2 centimeters inside, then you can do a segmentectomy in these patients as a preferred option and try to preserve as much of the lung tissue for them as possible. Now, there are some patients who don't meet that criteria from a size, but they meet the criteria from a nodal status. That is, they don't have lymph node involvement, but the size of the tumor might be above 2 centimeters, but they have really very poor lung function. And sometimes we might need to do a wedge resection for these patients with systemic lymph node dissection if they are not keen on other modalities of treatment that have to be discussed with them as well. Now, whenever we are in the clinic, we have to be very honest with the patients, and we have to tell them about all the options that are available to them, and we have to be very clear. So if they are super fit patients that have a disease which is surgically manageable, then we tell them that surgery is the best option for them. But if we have patients who are really poor, who have high risk from their operation, high risk from their mortality, the tripartite assessment is telling you that most likely these patients are not going to do too well following the operation, then they need to be aware of all the options. Obviously, all the patients need to be aware of all the options, but these patients, you should tell them that SABR might carry a reasonable role in their treatment. It might be good, especially if the tumors are small in size, and from a mortality perspective, it might have a less mortality to them and might cause less comorbidities to them compared to surgery if they have very poor lung function, or if they have, for example, severe heart failure or LV dysfunction or something like that. The other radical treatment options that are available are radical radiotherapy, chemoradiotherapy with radical intent. So these are all things that can be offered to the patients and can have a good outcome, particularly in patients who are at high risk from surgery. Now, in conclusion, our tripartite assessment is extremely essential in thoracic surgery, looking at the mortality, looking at the cardiac morbidity, and looking at the respiratory morbidity. Any patient who should have an FEV1 and DLCO assessed, and those who have an FEV1 or DLCO which is less than 40%, they are at higher risk from developing complications in the post-operative period, and they might need to be assessed by other tests, including VQ scan, shuttle walk test, cardiopulmonary exercise testing, and we said that we can accept patients who have a lower predicted FEV1 and DLCO down to 30%, as long as they are accepting the risk and as long as they are accepting they might need home oxygen. And don't forget as well that nowadays we are doing more VAT surgery, we're doing more robotic surgery, and I think these patients are likely to have, especially these patients with poor lung function, are likely to have a better outcome from their operation if it is minimally invasive compared to an open procedure. And then consider less resection in suitable patients with poor lung function, as we discussed, especially segmentectomy, if patients can tolerate that whenever the nodal status is negative. And be very honest with your patients. And if your patient is really high risk for surgery, then discuss other modalities of treatment and let the patient decide. If the patient insists that they want surgery and you think as a surgeon that the benefits from the surgery outweigh the risks, even if the risks are slightly higher, then you could consider doing it, as long as you try your best to optimize the patient prior to your operation. Thank you so much.